It's a great pleasure to come back and be part of a great faculty that Rod and Jens have put together, and just an incredible all-star cast of people that each year this program keeps getting better as well. And I'm going to talk about a kind of a topic today, and I love the word, the integration of technology in the operating room. And I'm supposed to teach you how we're going to do this talk and show you the benefits of navigation and relying on navigation. And some of this actually is there's a little bit of repetitive, which I have a lot of slides in here, and I'll probably skip a few in the interest of time, just because you heard from Nick Theodore and Rick Chua and also Andrew Manista and talked about these things. But I mean, this sounds kind of silly, but what does integration mean? And it means a combination, amalgamation, incorporation, unification, consolidation, merger, and the list goes on. And that's really what happens in an operating room. And I was talking offline with a couple of people, and it's like what happens in an operating room is not about the surgeon, but that's the only person that's really seen. And what does integration mean? And it's all the functionality of medical equipment and video and data and everything that we do there. And the primary driver for this new integrated technology is the minimally invasive stuff. I mean, and that's what everybody focuses on now, but it kind of grew up through navigation, because everybody always they always made fun of us, and they looked at it and said, oh, gee, you guys don't know how to put pedicle screws in unless you have this navigation system. I said, no, we put them in better, and we don't have takebacks. And so now everybody uses it, 10, 15, it's actually going over 20 years now. And it's the integration of these things, and it's all the equipment that we use. And it's not just the surgeon, that is the focal point, but it's all those people that are in the back of the room. It's all of those things that are happening that make us be able to work or not in an efficient way. I'm still trying to find that arrow again. There we go. And so the reality of a complex operating room is that, things are inefficient, they're overcrowded, the turnover takes a long time, new technologies are introduced haphazardly. I mean, I love that word, haphazardly, in a technologically complex environment, and we've got all these different things that have to come together to make it work efficiently. And we heard a little bit today about having teams and having people, the right people. I mean, going back and looking, and I'm not going to talk too much history, but we started doing this stuff in the mid-90s, and I published a few papers back then with here's some guys that are here that are on faculty at different places now. They were my fellows and residents back in the 90s, and we used to have to do a little tape that we'd take the CT scans and we'd put them in the image guidance system. We'd have to do navigation that was based on point referencing, and we used to have to do all this stuff. But there were things that we integrated together, and there was a paper that was done over at Barrow. It said you could only do 80% of patients C1-2 fixation because of the anatomy, which was probably true. But that was based on your anatomic landmarks, your knowledge, and your fluoroscopy. But if you look at these things, and we went back and studied them, and then we did patients, and it's like, no, that 20% of patients you can't operate on and you can't fix with those things, we lowered that down to about 5%. And it's just stuff that we did in the operating room. We did it in the laboratory. We can see from these things that, we studied these things systematically, and this is how to integrate this technology in the operating room. So it reduces it down to about 5%. But I think it's even less than that now. There are some new tricks that we do with being able to put fixation. And, this is all the way back to Jürgen Harms when he described putting in C1-2 pedicle screws and published it in December 2001. And we missed our publication on this, which I met him and I talked to him and I said, this is really cool stuff. We've been doing it. I'm trying to advance this slide, which advanced twice. Sorry about that. Going back. Anyway, we published a paper a month later. Basically the same thing, and it's about how to put these things together. And we started teaching ourselves how to do this with image guidance. And these are the things that we would be able to do, is even do an arthrodesis with image guidance, and how to use this technology and integrate this in the operating room to create an arthrodesis inside of the facet joint, which was not a place we wandered when we were young surgeons. What about other integration of doing thoracoscopy and being able to do complicated things like thoracic disc herniations and being able to put together the endoscopy and the VATS technology, and we merged that with image guidance. And these are all things that just took integration of these things and putting what I say is a lot of furniture in the operating room. And these are the steps that we used to go through. And they actually have, look at this thing's going a little bit slow. And they got faster with new integration of better technology. And these are some of the registration things that we used to have to go through these steps. And these were old video monitors. They look like TVs, don't they? Old stuff that we used to use. And we started using these things. We put a reference frame on the back of the patient. And this was published back in 2005, which means the work was done in a few years prior to that. So this is like 20-year-old technology. And this has been fast forwarded now to some new technology that we have with especially things like intraoperative CT scanning, that we can do instantaneous registration and we know everything. And this is taking a tumor out of somebody's thoracic spine that we used it endoscopically with image guidance. And these patients and people, and I'm not going to show this video because it takes too long, but it's a neat video. Or maybe I'll start it. So there's a big tumor inside of this patient. Here's what it looks like on the images. Here's what it looks like when we're operating on it. Through portals in the chest, take out a big tumor. It's all extra-axial. It's a big nerve sheath tumor. But these are things that they're integration of all these different pieces of equipment. Here's a game changer, okay? Intraoperative CT scanning. This thing just changed what everything was a problem with navigation and image guidance. It revolutionized what's happening is that we now are able to do these things. There's supposed to be a video that plays of it coming in there, but I'll go past it. There we go. But anyway, to be able to do this has really changed what we do nowadays. And so what's the current spinal navigation that I call second generation? What should we navigate? And I look at this and say, there's basically nothing that we can't navigate in the spinal column. I mean, anywhere from the craniovertebral junction to transoral surgery. I'll show some cases like that. And we can even do things that are deep down in the distal end of the sacrum. We can navigate anywhere. We can see and make us better surgeons is what all of this integration of this is. And if you look at all of these things, we went from old TV cameras to flat screen technology, and this is just the continuing advancement of all this stuff. And this was actually a kind of a third generation of what we were doing with image-guided navigation and thoracoscopy. I still do those because I think it's the best way to do a thoracic disc. I can do it without doing a fusion in the patient. I can go through and make a little tiny opening for a great big huge disc herniation like this. And it's bringing to bear all of this technology in the operating room at one time. Navigation and fluoroscopy. And fluoroscopy has been eliminated, and we use endoscopy, and we use a lot of high-powered drills and equipment to be able to take these things out. These are fun operations to do as a surgeon, but it has required that we put together all of these things. So here's a reference frame of a patient laying in a lateral position. I gave a little lecture about this a year or so ago at one of our other meetings up in Seattle, and I think it was really good about how to use different navigation techniques to be able to navigate the entire spinal column. So that's part of the integration, is being able to put these things together and make it work. So here's thoracoscopy. I mean, we do it through portals in the chest. And that's not all I do either. Believe me, we do everything that's, every application you could do. But this is just some examples of what I call really high performance things that take a lot of integration of different technologies to make it all work. This is one of the other talks that I give, is expanding the applications of image guidance. And you can put a reference frame on anything. You can use it for reconstruction. You can use it for decompression and biopsies and tumor resections. As I said, even the treatment of infections. And, we've just been doing this a lot of different places. And sometimes, there was an example that I gave one lecture is about how many people have done an OPLL case in the front of a cervical spine and gotten a post-operative CT scan and see a great big piece of bone that you missed. Now, you can eliminate that with image guidance up front. And if you don't think you're confident about having done it in the end, you can do another intraoperative CT scan. So it's precision. It's making good surgeons better. It's making great surgeons, I think, incredible, is that this technology has just helped us. And that's the way everything should work. I mean, does anybody not use GPS from their phone? I mean, that's what all this is like. You know, all this data. I mean, it's like, look at revision surgery with navigation it's probably less than this in our hands. But these are published data out there. Is it freehand? They're somewhere in the 10% range. I remember when we started using navigation, and some of the people were not. I mean, we used to have patients that would be taken back to the operating room probably every single month at a big place like Cedars doing 3,000 cases a year, but every single month we would have takebacks because they were freehand, they were fluoroscopy, they were all of these cases. Those numbers have declined to where the number of patients that get taken back, because almost all the surgeons use navigation and they bring all this stuff to bear in the operating room, is that we probably only have a handful of takebacks in a year's time. Now, not everybody's an incredible surgeon like Jens Chapman can put a screw anywhere and never have a miss. I mean, I wish I had that kind of skills, but we use it on computer guidance to do this stuff. I'm going to kind of breeze through some of this. Anterior cervical. These are complex places that we use navigation, but these are just some of the things that we do and how we set up some of our reference frames. And we use CT scanning, and we got techniques that even how to tape the patient down to a Jackson table to make it more rigid, where you have less errors in the navigation accuracy. So we get this kind of precision, and it looks like this reference frame's a long way off, and you're right, it is. But there are little tricks that we have developed, and some of them we still got to publish these things, because they're just things that surgeons need to know how to do and bring all of this technology to work. And it's not just what we're doing here, putting screws in, but everything has to work in the operating room. All these people, all the technicians, and having the technicians to be able to do these things. So what about something like this? I mean, here's a congenital cervical deformity problem with a Klippel file. The patient's got an incredibly narrow spinal canal, severely myelopathic. She's a nurse from a nearby university hospital, and she has a big tumor in her head too. You can see up here, don't miss that, neurosurgeons out there, but that wasn't her symptomatic problem. She needed a navigated decompression. She needed a navigated reconstruction, and all of these things that go together. Here's somebody who did this operation. I don't even know what they did out there, but that's probably the biggest screw I've ever put in the human cervical spine. But she did well and went back to work, and that's what it's all about. And here's some deformity things in the cervical spine. I'll go through them rapidly. We published this back, this isn't my paper, but we published this back in, I believe, 2009, and it's how to do PSOs at the cervical thoracic junction. And it's just utilization of everything that's in the operating room, from the navigation to the neuromonitoring to utilizing. And we taught ourselves how to do this operation with navigation, really. I mean, I can do these operations without navigation, but I do them better with. And yeah, it was back in 2009 that we published this series that we had done, and we built upon that and probably need to revisit it. Next slide. There we go. So these are just some of the pictures of what we can do and how we can utilize this technology to bring better things to bear. I don't know where that came from. I have an extra slide. So I think I have a couple videos that probably won't play. So what about craniovertebral junction problems? This is a transoral case from a Boeing engineer. And he lives in Los Angeles, and he needed a transoral operation. But these are operations that we bring all these things together. Here's another patient, had a complex deformity of the C1-2, and had cancer, had a pathologic fracture. It healed in a bad position. That looks like a bad position. And so we basically had to do a transoral osteotomy of C2, part of C1, turn him over from the backside. But these are all the things that we have to bring together, all the navigation and complicated surgical procedures to put this guy back together after we very carefully take him apart. And so these are just some of the steps of the way. And that's actually a part of the reconstruction of a large piece of ilium that we put this guy's spine back together with, and then use navigation to instrument everything. And there's the odontoid lopped off. And here's the posterior operation. And all these steps and parts. And that's a short segment fixation. We talk about how can you do this? I mean, if you can put incredibly well-placed C2 pedicle screws and you put them out to the front cortex, you can get away with a short segment fixation like this in a complicated case, and it's bringing together all of these things that you use. What about thoracic spine? I'm not going to talk about this too much because it's been covered in a lot of our deformity, but it's how to navigate. There's a paper we published about small pedicles. Dave Polly was part of some of these talks. This is an old slide about doing front-back surgery. This is about doing chordoma resections. It's all navigated technology. This was back when I was at UCLA, which is now over 19 years ago. But here's another recent case that's actually a guy who had a great big huge calcified thoracic disc. He'd had multiple other operations on knees and everything, that there were other thoughts that as to why he was having walking problems, but these are all navigated procedures. What about lumbar spine? We do these anywhere from minimally invasive with small reference frames to some of our medium-sized open operations. These are some of the percutaneous things that we do. It's all based on intraoperative navigation and putting a lot of equipment in the operating room and getting these people to work together. Well, deformity and calibration, and these are MIS. And we do actually a lot of guide wireless work now that we're moving into the robotics world as well. But this is just looking at percutaneous fixation from image guidance. Next slide. And this is looking at guide wireless deformity. I'm going to skip past deformity because that's a whole lecture all in itself. A lot been published about accuracy, safety. Lots of papers, lots of data. Incredibly good. We need navigation. We can't do it as well as Dave Skaggs when he's doing 98% accuracy, or is it 99%, Dave? I can't remember what you said. But these are some of the adult cases that we do. They're big, complex cases. I won't go into all the data of each one of them, but it's actually what can we do post-operatively to fix these kind of difficult problems. Every one of these, computer navigation from every one of them. Keep going. Accuracy, I can look at these things. We're getting close to Dave Skaggs at 97% with these things is what we do these days with accuracy. Pelvic fixation, we've made it a lot simpler. Dave Polly's really good at doing pelvic fixation. We use navigation for all of them, and Dave has become a navigation expert. He's a wonderful guy. We've collaborated on a lot of research. What about looking at some of the human factors? And this is kind of getting into what's the fun part of this lecture and why I've kind of tried to go as fast as I could here. But we're looking at all of these things, and this is, what it takes for a complicated operating room. This is for a cardiac surgery room. I mean, where they've got surgeons, they've got a nurse, they got nurses, they got anesthesia people, they've got all of these different people, but it actually gets more complicated, I think, when we do some of our big reconstructive procedures for navigated deformity. This is the old stuff. We used to have a surgeon, a radiology tech, and a scrub tech, and nowadays we have a surgeon. We have a navigation tech. We have a radiology tech. We have anesthesia. We have a scrub tech. We have an implant rep. We have a nurse as usual. I mean, these are all the basic people, and I don't know whether this video is going to play or not, but these are just fun videos to look at. And we have gone to, and we actually have a grant that we're in the midst of publishing some of this stuff and going on and doing it in the robotics side right now. It's just going to play. Yeah, there you go. So these things are almost, they look like ants in here with some of the time-lapse videos. They're not playing anywhere near as fast as they're supposed to. I think it's a streaming thing here. But anyway, it shows all of the different people in the room, and it's supposed to show that it's somewhat bedlam when all of this technology is in there at one time. And it's how do you make it more efficient? Because if you have one person that slows it down, and maybe consistently, that's a problem. I'm going to skip this one because Nick had showed one about looking at pit stop technology and going back to the 70s and 80s when they take a minute to do what takes now 10 or 15 seconds to do pit stop racing. And it's just changed the way it is. But what about human factors and human performance in the operating room? Is that some of these things, here's a guy, Ken Catchpoles, is actually a PhD, and he's a human performance guy that we work with, and he's been at Cedars in LA, and he just unfortunately moved away. But he still works with us, and he's looking at flow disruption, traffic-related factors, their impact on flow disruptions in the operating room. And so this is what we're working on. And we published this, actually, this is one of the talks and papers that came out of Seattle Science Foundation. It was one of our navigation meetings that I'd encourage you all to try and attend if we're doing those things this coming fall. But it's making all of these things work together. Now that we go into robotic surgery, it's probably even more complicated. And here's an article about Nick Theodore and the incredible work that he's done to bring this technology. But what we have done in our operating room is that we've fortunately just moved into some new operating rooms. We've dedicated one of our rooms as a robotic operating room. We have a dedicated group of people. It's not the exact same people every day, but it's a cadre of people where we have 2 or 3 scrub techs, and they want to do this stuff, and they're in there and they make it work, and they're just able to bring all of these things together from the back of the room. And we have some of the tech people from the company as well. I don't know whether this video will play, but this is a neat video, and I just want to let it play rather than spin through it. Linda, is this one going to work? So this is one of our fellows, and unfortunately it's playing slow. It's not even real time. But this is putting 1 pedicle screw in with the robot. Okay, and all the pre-planning is done, and this is putting 8 pedicle screws into this patient. This is streaming very slow. But anyway, this is one of the fellows who's doing it, and he's become very proficient, and the scrub tech back there makes him look really good. I wish I could see this go in real time, but the scrub tech has every single instrument ready to go. It's go step, 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 hammers in this tooth spline, it anchors it, he takes it out. It's kind of, I just wanted this video to play real time. Now it's going slow time. But anyway, this is drilling the pilot hole. He hands the instrument back to the tech. Pardon me. Hands it back to the tech, and the tech unloads, reloads. It's got a tap. It's all power equipment. Everything's been set up. But as we go through this thing, trying to find the play across it, but it took 2 minutes to put in 1 screw. So the entire time that it took us to put 8 screws in that, and you multiply it by 2, and you add a few seconds between each one for the robot to change its position. But it's all about having a robotics team, and we have a robotics team that makes this thing work. And what's interesting to me is that I've always looked at some of these things as slowing you down, but this technology, once it's in place and it's ready to go and working, is that placement of 6 or 8 pedicle screws for a robotic navigated case takes about 2 to 3 minutes per screw. So if you total up the time, 6 times 3 is 18 minutes, and those are the times that they're working at. So this is actually a paper that was looked at by Mike Wang in Miami, and he actually looked at his different residents, and it's like the younger residents actually did better than the older residents. And that kind of goes back to these younger minds, that even the chief resident level people, they had too many bad habits that they probably already learned. And so they basically were better off with the younger residents and fellows. But this is a training program, and actually it's kind of the steps is that we learned how to use the software. We did tutorials. We got our best team together, best scrub tech, RNs, and we got the reps, and we got the robotic specialists, and we had dry runs to do these things that we did with sawbones, and we put together the. Oh, my office is calling me. Sorry about that. And so we had all of these things to start our robotics center. We went down and visited the guys at UC San Diego. They got a great group of people. They've got a head start on us, and they taught us about some of the little tricks of the trade about this. And so starting up our center, we went and visited a bunch of people. We had a couple visiting professors come. Richard Chua came, visited us. Who just happened to be on our panel and speaking for us today. And so he went over the workflow, and he gave us a lot of tips, and we really thanked him for that. And I did during our little break. And we did our first case actually just about 6-8 months ago. Things went perfect, and we have been doing cases almost every day of the week now. So what is it? The future of these things, and it's not just about robotics. This talk is really about, and it's not about the future robotics. You already heard that from the real experts before me, but it's how do you utilize all of this technology and you make people efficient in the operating room and how they can actually do these things. I wish these things played as fast as they could. There they go. But it's like little ants in there, and it's all the people that are in the back of the room and you can't see here. It's not just the surgeons, because all of these other people are absolutely essential to make the surgeons look good. We'll move on. So what is it going to look like in the future? Well, you're going to have integrated operating rooms. I mean, we're going to have high-tech things that these are here and now already. I mean, we're doing these things. The developments that we do with the operating room transformation, multidisciplinary, hybrid operating rooms. I mean, even things that, to me, they look more futuristic in every iteration that you do. This looks like a nuclear submarine to me, but it's actually an operating room of the future, digital operating room. Cool stuff. Trying to make the slides go. But anyway, I had some conclusions there. I don't know if I can go back and read them. But anyway, all kind of somewhat obvious. Ability to adapt a complex thing to make it workable in an everyday case. The equipment's got to be compatible. You got to have the equipment. The people have to be able to do it simple, though, and set it up rapidly. You have to have smaller components. All these things are going to get smaller as far as the size of the boxes that the equipment comes in. It has to have simple setup, and it has to work for people. And you have to put together these teams. But the human factors are probably the biggest challenge of all, is to get everybody to work together. That's the real challenge that we find. Anyway, I appreciate the opportunity, the invitation to talk. Great group of lectures, and I'm glad I can contribute hopefully something to it. So thank you very much.
Well, thank you. Really appreciate that talk. And just wanted to open up for any questions from the group. Just have one coming from me over here. I know we've talked about maybe getting access to a robot in our hospital system. So far, we haven't been able to. And it's really helpful to hear all of those things that helped you become efficient and all of the things that go into having it work well, because you can't just have the robot show up there the first day. And in terms of having that dry run, I mean, talk a little bit more about what you had to go through with that team to get them comfortable bringing that robot into the OR.
Well, it comes from a highly experienced navigation team already. And we have been doing so much navigation, which is the basis of it. It's a computer guidance procedure is what it is. And it's having a machine that basically lines it up for you to put screws into people. It's not putting the screws in for us yet, but it will. Okay, that's kind of a long leap away, but I don't think it's that far away. But it's already having your key people that are used to doing things like intraoperative CT and navigation. So it's just using a new machine with that technology, but there's a lot of new things to it. There's a lot of little caveats, and having as much experience as you can before you do your first case, going and visiting people, going and taking some courses where there are very few of them that are available, but visiting people and actually seeing in the operating room. I mean, you guys, experienced surgeons, can learn so much by simply walking into somebody's operating room and just watching. Okay, you can absorb things that you don't have to go read a book, you don't have to see it online, but if you go stand in somebody's operating room and you see how those things work, you'll probably learn the most.
Great, thank you. Any other comments or questions from the group?
Nick Theodore, you got any questions? You're a smart guy. You're the smartest guy here.
Far from it. I think it was beautiful, Pat, and I think that every time I hear you give that talk, it gets me thinking. And I just did some screenshots of some of those articles. I think, to your point, it's how does everything integrate? And first of all, for the people who are practicing, how does everything integrate? And then the second thing is, I guess, and Ed's asked this question to me, I'll ask it to you, who has a robust fellowship program. How do you see this technology? And everybody leaves your program as adept at the technology, but I guess how do you see this transcending into the resident education, and where do you see the future of all of our training go when it comes to the adoption of technology?
Well, I think it's a natural progression for high-tech things to develop. I mean, who is going to be able to drive a self-driving car? Everybody, right? Pretty much everybody. When it comes to surgeons, people are going to select for what they do. And the car is not a great example of that, but the car is adaptable to everybody. Your GPS on your phone, okay, everybody uses. But when it comes to surgeons using these things, they're going to decide which ones they like. Okay, they're going to decide whether they want to do these things with what we consider old school navigation right now, or do they really want to be a robotic surgeon? I think it's available. Even practicing can do it. I mean, if you're too young to retire and too old to retrain, that's not quite the case, because you can actually go learn a lot of these things, and there are great places around. I mean, the guys down in San Diego, I was highly impressed with them. I mean, the guys down Martin Pham and those guys down there, they got a beautiful program, a beautiful lab, and they're just, I mean, it's a great place. If anybody wants to learn about how to do the procedure, that's easy. It's the integration of people in the operating room, and you've already done that. You've been through this, Nick, is that you have put that together before anybody else was doing it. You know how to use navigation. So your trainees, and back to your question, trainees come through your program and they're going to decide what they want to do. First of all, they're going to decide if they want to be a spine surgeon or not, because that's a specialty all in itself.